I really love this quote. Minimalism is the pursuit of the essence of things, not the appearance. When MIS techniques started to come out, we rated things like incision size. Now we're rating things like length of stay, estimated blood loss, um, uh, morphometric analysis of atrophy in the muscles. Um, these are my disclosures. There's no remuneration for this presentation. I am a teaching consultant for Stryker in terms of MIS techniques and navigation. The objective of this talk is going to be mostly from a community-based private practice surgeon, but really the application of MIS surgery with image guidance. And we're going to talk about some of the benefits of MIS techniques and to identify when MIS techniques is not beneficial in spine surgery. So this is our starting point. A lot of us, you know, when I was at the University of New Mexico, I said that you have to put aside your occipital lobe. You have to use more of your parietal lobe because this is our starting field. It's the bare skin of the patient. And like Dr. Johnson mentioned, a lot of times we don't even see the spine. We're using computer-assisted guidance system. So one of the questions I have is that when do you implement MIS techniques? When do you implement image guidance techniques? You've heard a lot of talks about image guidance techniques with deformity and open procedures. But in my practice, I implement a lot of MIS techniques, and we'll go over some x-rays. But it really comes from using open anatomical landmarks and minimally invasive anatomy together. These things aren't done in isolation. They're done in combination, and that's why there's a cross arrow between those two, because when you can't do something MIS and you have to open, then there should be a low threshold to be able to open a procedure and to do it open. When I do my procedures, I have to be able to flip between fluoroscopy and 3D anatomy. Sometimes I use 3D anatomy to confirm placement of screws. Other times I'll use fluoroscopy anatomy to confirm placement of screws. And really understanding the principles of navigation. We talked about line of sight, reference points. And one thing that I would like to add is that the timing of the navigation is really important to your procedure. Whether you're doing an MIS T-lift, do you do a decompression first, or do you place the hardware first? The timing of navigation before you enter the room is extremely important in increasing your workflow. You know, for me, if I'm implementing MIS techniques, I try to do it with pretty much all the adult degenerative cases that I can think about. But understanding the open anatomy first plays a huge role in trying to implement MIS techniques. Sorry about that. This is the system that we have in our facility. We have Medtronic navigation as well. But for the purposes of footprint and usability, this is something that I've kind of, you know, gotten familiar with. This image is up because you can see the footprint of the C-arm is smaller. It's not an O-arm. I actually use this machine to take both 2D and 3D images. Some of the reference points have been a little bit updated. This system uses active trackers. The picture in the middle is more of an active tracker. It requires a battery. It's called the Ingenious Tracker, and you can put it on virtually any kind of tool that you want. The image on the left is, it's called the spine mask, and instead of using pins like a lot of us do, a lot of us use pins for reference points. The spine mask just basically adheres to the surfaces of the skin. I'm able to do 4 levels, 5 levels of percutaneous screws within the confines of the mask itself. So that's without having to make extra incisions to go into the pelvis. This is my working screen. Typically, for someone like me, I would do the decompression first before I would place the hardware. I would use a spin to place the hardware, and this is done specifically using the spine mass technology. Some of the benefits of minimally invasive spine surgery. So over the last 20 years, there are more and more papers coming out about this. There's a certain trend for community-based neurosurgeons like myself to use MIS techniques, probably because of the length of stay and the less of blood loss. But we're going to go over some slides that show the use of narcotics and the use of physical therapy is also improved. This is a summary by our very own Dr. Drazen here, looking at the differences between MIS laminectomies and open laminectomies, MIS T-lifts and open T-lifts, and percutaneous PLIFs versus open PLIFs. And what is significant is that the p-values of MIS T-lifts versus open T-lifts are very different. They're the ones that are truly significant when you do open T-lifts versus MIS T-lifts. You have a improved visual analog scale, improved blood loss, and ODI. So this is a group out of Vanderbilt, published in World Neurosurgery in 2013, talking about the direct and indirect costs of open versus MIS techniques. You can see that at the very bottom, the total cost of an MIS T-lift is significantly different than an open T-lift. And above that, the indirect costs are things like postoperative narcotics and postoperative physical therapy and rehab visits. So some of the direct costs to the hospitals were also mentioned, open versus MIS, and before we were talking about navigation versus not navigation. But this is a group out of New Orleans talking about the direct cost to the hospital of MIS techniques versus open techniques. And you can clearly see a huge difference between the average cost of these procedures. So the benefits of image guidance surgery with MIS techniques. Well, sometimes you really want that improved accuracy of trying to get into the pedicle and your surgical target. If you're using image guidance for your approach, like laminectomies or tumor resection, or if you're confirming trajectory or placement of the hardware, often a lot of these platforms will improve your confidence before you leave the operating room for very difficult anatomies. So why minimally invasive spine surgery versus with image guidance? It's two really powerful tools combined together. All the advantages of MIS surgery with the improved accuracy, which is what we talked about over fluoroscopy. I'll talk about some of my experiences in a little bit. It is very cumbersome at first. Thinking about MIS procedures without navigation might be the first thing, but over time, being facile with MIS techniques will reduce your overall operating time and radiation time. Also, the need for confirmation is going to be lower. This is the learning curve. My learning curve, actually, it is the steepest in open procedures. When we're all in training, we want to do things open and freehand, and then we implement things like fluoroscopy. And then over time, you're trying to think about smaller and smaller incisions and less muscle disruption. Some of the techniques that are used, actually I don't have those slides, but you know that the next iteration to open procedures is going to be MIS, whether you're like Dr. Wang at the University of Miami, where he makes a midline incision and he does MIS techniques through muscle splitting techniques, or myself, where I use Wilsey approaches. The next iteration might be robotics, and so that's my learning curve. when not to use MIS and image guidance together. Well, if this is your first time with MIS, maybe doing it conventionally with navigation, learning one tool first versus implementing both of them for your first go at it. You know, if your reference point cannot be secured, for instance, like in patients with that are over the BMI of 35, the spine mask will tend to translate, and so in those patients, I have the versatility of using hip pins. My clinical experience over the last 12 months with 1 to 4 level fusions, thinking about cases that need revision. These patients have a grade 2 or grade 3 medial breach causing symptoms with MIS techniques and navigation. What I did was I basically treated them like any radiculopathic patient and then just simply removed the screw without having to revise that, and you had complete resolution of symptoms. And here are some examples of my own screw breaches. Evaluating my own work for 1 and 2 level T-lifts, the radiation time over the past several years have diminished. It's below 2 minutes now. It's about 1.5 minutes. But really what's important is the amount of radiation that's applied to the operative field. During the spin, like every other navigation spin, we tend to step out of the surgical field beyond 6 feet. For my 6 to 10 level, what I call tri-brids, X-lift, T-lifts, those they tend to have more radiation in terms of confirmation spins, but the important thing is to grade yourself in terms of the amount of radiation that is in the operative field. In 2017, our hospital extensively talked to us about what's coming down with CMS and things like the reimbursement rate, the MIPS. They do look at things like your readmission rate, and over the last 12 months, my readmission rate is 0.5 with these particular type of procedures. And so I think that the argument is, can you use MIS techniques with image guidance to reduce your readmission rate, to reduce things like reoperative rate, in which we know the cost of. This is just an example of some of the stuff that navigation with MIS techniques can do. You'll see that some of the cages between L203 and L304 are lateral cages. There are little fiducials around the surgical field. That is the spine mass itself, and that's what it looks like. This is an AP view just to confirm placement of the hardware. And this is an example of another tri-brid procedure where hip pins are placed to hold the reference ingenious tracker. So thank you very much.